Heart failure. This is a pathophysiological process in which the heart, as a pump, is unable to meet the metabolic requirements of the tissue for oxygen and substrate, despite the venous return to heart is either normal or increased. Cardiac output, stroke volume into heart rate, becomes insufficient to meet the metabolic needs of a body. SV, which is determined by the preload, afterload, and the myocardial contractility, ejection fraction, and the classification of the heart failure will be systolic failure, diastolic failure, and mixed. In systolic failure, there will be the decreased contractility, and diastolic failure will be the decreased filling. Factors affecting the heart pump effectiveness. In preload, there will be the volume of blood in the ventricles at in diastole. They may depend on the venous return and they depend on the compliance. In case of the afterload, forces need to eject the blood into the circulation. Depend upon the arterial BP, pulmonary artery pressure. The valvular disease increases the afterload. Ejection fraction, one of the measurement used by the physician to assess how well a patient heart is functioning. Ejection. This refers to the amount of blood that is pumped out of the heart's main pumping chamber during each heartbeat. Fraction. This refers to the fact that even in the healthy heart, some blood always remains within this chamber after each heartbeat. An ejection fraction is the percentage of blood within the chamber that is pumped out with every heartbeat. Normal ejection fraction will be like 52 to 75%. Stroke volume, which has the end diastolic volume minus end systolic volume. Ejection fraction SV by EDB. End diastolic volume, which is reached at end of the ventricular filling. Calculation of ejection fraction will be 90 ml by 140 ml equal to 64. EF 55 minus 65 will be the normal one. Heart failure. All organs like liver, lungs, legs, etc. return the blood to the heart. When heart begins to fail or weaken, unable to pump the blood forward, fluid backs up and increases the pressure within all organs. Lungs, they are congested, increase the effort to breathe. Fluid starts to escape into the alveoli, which is a pulmonary edema. Fluid interferes with the O2 oxygen hypoxia. This leads to aggravates the shortness of breath. Shortness of breath during the exertion may be the early symptoms and may it also progresses. Later, this requires the extra pillows at night to breathe, orthopnea, and they experience the PND, that is paroxysmal nocturnal dyspnea. Legs, ankles and feet. Blood from feet to lung, backup of a fluid and a pressure in this area as heart unable to pump the blood as promptly as received. This increases the fluid within the feet and lungs. This causes the pedal or the dependent edema and it increases in beta. Systolic failure. This is the most common hallmark finding, which is decrease in the left ventricular ejection fraction, which is nearly lesser than 40%. This is due to impaired contractile function, myocardial infarction, increased afterload, hypertension, cardiomyopathy, mechanical abnormalities will be the valvular disease. Diastolic failure. Impaired ability of ventricles to relax and fill during the diastole. This causes the decreased stroke volume and carbon monoxide. Diagnosis based on the presence of pulmonary congestion, pulmonary hypertension and the ventricular hypertrophy. The normal ejection fraction not much have the blood to eject. Mixed systolic and the diastolic failure. This is seen in the disease states such as the dilated cardiomyopathy. They have the poor ejection fraction which has a high pulmonary pressure. Biventricular failure. Both ventricles may be dilated and have the poor filling and emptying capacity. While speaking about the pathophysiology, the cardiac compensated mechanism will be tachycardia, ventricular dilation, 𝓻 law and the myocardial hypertrophy. Homeostatic compensated mechanism. Activation of the sympathetic nervous system. This will be the first line. In vascular system, this results in the vasoconstriction, that is afterload. Here, this takes place in the kidney, which has a decreased renal perfusion, renin-angiotensin release, aldosterone release, sodium and the water will be the retention. In liver, there will be store of venous volume causing the ascites and the hepatomegaly. Counter-regulatory response. This increases the sodium, that is the release of antidiuretic hormone, release of atrial natriuretic factor and BNP. Sodium and the water excretion, thus prevents the severe cardiac decompensation. Counter-regulatory response. Neurohormonal response. Endothelin, which is stimulated by the ADH, catecholamine and the angiotensin II. Atrial vasoconstriction increases in the cardiac contractility and the hypertrophy. Neurohormonal responses. Pro-inflammatory cytokines, example tumor necrosis factor, released by the cardiac myocytes in response to the cardiac injury. This represses the cardiac function, cardiac hypertrophy, contractile dysfunction and the myocyte cell death. Heart failure. While speaking about the pathophysiology of the neurohormonal responses, over time leads to the systemic inflammatory response. This results in the cardiac wasting, muscle myopathy and the fatigue. Counter-regulatory. Natriuretic peptides, HL natriuretic peptide and B-type natriuretic peptide, released in response to increase in the atrial volume and the ventricular pressure. This promotes the venous and the arterial vasodilation, reduces the preload and the afterload. Prolonged heart failure leads to the depletion of these factors. Consequence of the compensating mechanism. Ventricular dilation, enlargement of the heart chambers, which leads to the elevated left ventricular pressure. Initially effective adaptive mechanism, then the mechanism inadequate, leads to the cardiac output decrease. While speaking about the Frank-Starling law, this initially increases the venous return, results in the increase in the force of contraction. Later increases the ventricular filling and myocardial stretch eventually results in the ineffective contraction. While speaking about the hypertrophy, increase in the muscle mass and the cardiac wall thickness in response to chronic dilation, heart muscle poor contractility, increase in oxygen needs and the poor coronary artery circulation, prone to the ventricular dysarrhythmia. This causes the sudden cardiac death. Ventricular remodeling or the cardiac remodeling. This refers to the changes in size, shape, structure and the physiology of a heart after the injury to the myocardium. The end result will be after the fluid overload, the acute compensated heart failure with pulmonary edema. Heart failure classification system under the New York Heart Association functional classification, class 1 to 5. ACC or AHA, stages of heart failure, which is New Year, that is stages A to D. Class 1, mild. No limitation of the physical activity. Ordinary physical activity does not cause under fatigue, rapid or the irregular heartbeat, palpitation and the shortness of breath, dyspnea. Class 2, this is also a mild one, slight limitation of the physical activity, comfortable at rest, but ordinary physical activity results in the fatigue, rapid irregular heartbeat, palpitation or the shortness of breath. Class 3, moderate, marked limitation of the physical activity, comfortable at rest, but less than ordinary activity causes the fatigue, rapid irregular heartbeat, palpitation or the shortness of breath, dyspnea. Class 4, which is severe, unable to carry out any physical activity without the discomfort, symptoms of a fatigue, rapid irregular heartbeat, palpitation or the shortness of breath, dyspnea. These are present at rest. If any physical activity is undertaken, discomfort increases. In stage A, the patients at a higher risk of heart failure but without the structural heart disease or symptoms of the heart failure. Example, hypertension, diabetes mellitus, obesity, coronary artery disease, peripheral vascular disease, CVA, family history and exposure to the cardiac toxins. In stage B, the patient with a structural heart disease but without signs and symptoms of heart failure. Pre or myocardial infarction, left ventricular hypertrophy or the reduced left ventricular ejection fraction and the asymptomatic vascular disease. Stage C, patients with a structural heart disease with a prior or the current symptoms of the heart failure, non-structural heart disease and the dyspnea, fatigue, reduced exercise tolerance. Stage D, patients with a refractory heart failure requiring the specialized intervention, mark the symptoms of the rest despite maximal and the medical therapy with recurrent hospitalizations. Primary risk factors will be the coronary artery disease with advancing age, and the contributing factors will be hypertension, diabetes, tobacco use, obesity, high serum cholesterol, African American descent, valvular heart disease and hypovolemia. The major reason will be the disorder of the coronary artery and the high blood pressure, abnormal heart rhythm, cardiomyopathy and the heart valve disorder. Impaired cardiac function with coronary artery disease, cardiomyopathy, rheumatic fever and endocarditis. Increased cardiac workload will cause the hypertension, valvular disease, anemia and the congestive congenital heart defect. Acute non-cardiac condition will lead to the volume overload, hyperthyroid, fever, infection. Systolic versus diastolic. Systolic, loss of contractility, they decrease the carbon dioxide. Diastolic leads to the decreased filling of the preload. Left-sided versus right-sided. Left ventricle, lungs. Right ventricle goes to the peripheral region. High output versus low output. Hypermetabolic state. Acute versus chronic. Acute MI, chronic cardiomyopathy. Symptoms will be shortness of breath, swelling of feet and leg, chronic lack of energy, difficulty in sleeping at night due to the breathing problem, confusion, impaired memory, increased urination at night, cough with frothy sputum, swollen or tender abdomen with the loss of appetite. Signs and symptoms will be dyspnea, orthopnea, PND, chain stocks, fatigue, anxiety rails. In orthopnea, that is the dyspnea on lying the blood to the pulmonary on lying state, which causes the blood to the pulmonary circulation while recompliant. Paroxysmal nocturnal dyspnea, attacks of the severe shortness of breath and the coughing that generally occur at night. It usually awakens the person from sleep and may be quite frightening. This caused in part of the depression of the respiratory center during the sleep, which may reduce the arterial oxygen tension, particularly in patients with a reduced pulmonary compliance. Also in the horizontal position, that is the redistribution of the blood volume from the lower extremities and the spaltic back to the lungs. Little effect in the normal individual, but in patients with the failing left ventricle, that is a significant reduction in the vital capacity and the pulmonary compliance with the resultant shortness of breath. Heart failure with the clinical manifestations, the acute decompensated heart failure causes the pulmonary edema, often life-threatening. In early cases, there will be the increase in the respiratory rate and a decrease in the hypoxia, that is oxygen. While speaking about the later stage, there will be the tachypnea and the respiratory acidosis. In clinical manifestation of the acute decompensated heart failure, physical findings are orthopnea, dyspnea, tachypnea, use of accessory muscles of respiration, cyanosis, cool and clammy skin, S3 rhythm, hypotension or the hypertension, tachycardia, breath sounds like crackles, whistles, bronchi, cough with frothy blood-tinged sputum. Right heart failure, signs and symptoms will be fatigue, weakness, lethargy, weight gain, increased abdominal girth, anorexia, right upper quadrant pain, elevated neck pain, hepatomegaly, may not see the signs of LVF. Cough, pulmonale or the right-sided heart failure is an enlargement of the left ventricle due to the high blood pressure in the lungs, usually caused by chronic lung disease. Complications will be the pleural effusion, atrial fibrillation. This is the most common dysrhythmia, loss of atrial contraction, kick, necessary for the 20 to 25% of a cardiac output, reduce carbon dioxide by the 20 to 25%, promotes a thrombus or the embolus formation, increase the risk for stroke. High risk of the fatal dysrhythmia, sudden cardiac death, ventricular tachycardia with the HF and then EF nearly less than 35%. Heart failure leads to the severe hepatomegaly, especially with the right ventricular failure, fibrosis and the cirrhosis, cardiac cirrhosis, they develop over time. Renal insufficiency of the failure, cardiorenal syndrome. Initial evaluation, primary goal will be determine the underlying cause. thorough history and the physical examination to identify the cardiac and the non-cardiac disorders or the behaviors that might cause or accelerate the development or the progression of the heart failure. Volume status and the vital signs should be assessed. Diagnostic test: ECG, chest X-ray, CBC, urinalysis, serum electrolyte, calcium, magnesium, blood urea nitrogen, and serum creatinine, glucose, fasting lipid profile, liver function test, thyroid stimulating hormone, cardiac troponin, beta natriuretic peptide, and the arterial blood gas. Two-dimensional echocardiogram with the Doppler should be performed during the initial evaluation of a patient presenting with the heart failure to assess functional size, ventricular function, wall thickness, and the wall motion and the wall function. Echocardiography: EF is the single most important measurement in HF. It tells different etiology and type of HF, but there is no correlation between the symptoms and the effusion. Invasive hemodynamic monitoring can be useful for carefully selected patients with acute HF who have persistent symptoms despite the empiric adjustment of the standard therapy, whose fluid status, perfusion, or the systemic and the pulmonary vascular resistance is uncertain, whose systolic pressure remains low associated with the symptoms despite the initial therapy, whose renal function is worsening with therapy, who require the parenteral vasoactive agents. Coronary angiography if ischemia is likely cause of the heart failure. Emergency management: upright position and the nitrate. Common factors that precipitate the acute decompensated HF. Non-adherence with the medication regimen, sodium and fluid restriction, acute and the myocardial ischemia, uncorrelated with the high blood pressure, AF and other arrhythmia, recent addition of the negative inotropic drugs, verapamil, nifedipine, beta blockers, pulmonary embolism, initiation of a drug that increases the salt retention, excessive alcohol or the illicit drug use, endocrine abnormalities, concurrent infections, additional acute cardiovascular disorders. Heart failure stage 1: at the risk of developing the heart failure but no structural heart disease yet, which has the adequate BP control. Adequate BP control, adequate diabetes control, weight reduction, quit smoking, avoid cardiotoxins, lipid management, and the atrial fibrillation management. In stage B, there will be the structural heart disease without the symptoms. Care measure in the stage A along with the, they should be on the ACI, at the beta blockers and the spironolactone. If LVEF is nearly 40%, surgical consultation for the coronary artery revascularization and the valve repair replacement as appropriate one. In stage 3, they have the structural heart disease with over symptoms, non-pharmacological intervention, therapeutic lifestyle changes. They have the diet which has a low salt, low fat, rich in the fruit and the veggies, increases the fiber and water intake limited to the 1.5 liter. Smoking cessation, activity and exercise, duration of activity, exercise training and the rehabilitation at least 30 minutes, aerobic exercise or the brisk walking with 5 days and ideally 7 days a walk. Benefits: they improve the HRQOL, increase in the functional status, improve the exercise capacity and reduce the hospitalization and the mortality, improve the endothelial function and improve the O2 extraction from the peripheral tissue. Pharmacological intervention: all measures of a stage A and B, diuretics, furosemide 20 to 40 mg once or twice, hydrochloride, metronidazole and the spironolactone. Aims of the diuretic therapy on the outpatient is to decrease the weight 0.5 to 1 kg daily with the adequate diuresis and adjust the dose accordingly until the evidence is fluid retention resolved. Then daily wait and adjust the dose accordingly. In ACEI intolerant or alternative to ACEI, AT1 receptor blocker can be substituted to the ACEI with angioedema history but with a caution. The patient can develop the angioedema with ARB as well. Angiotensin receptor blockers. Losartan 25 to 50 mg once still 50 to 150 mg once a day. valves at on 20 to 40 mg twice, 160 mg twice. Same initiation and monitoring as ACE titration by doubling the dose. To all the patients with the LV dysfunction, early when symptoms improve, caution can worsen the heart failure, start low and go slow. Start in low dose even during the hospitalization. Careful in the patient require the inotropic support. Gradually increase the dose in the week's duration and try to reach target dose. Bisoprolol 1.25 to 2.5 mg once till 10 mg dose. Carvedilol 3.125 twice till 5 mg twice. Metoprolol succinate 12.5 once till 200 mg once. Continue even emergency is not improved. The patient is not improved. Upward withdrawal avoided. Digoxin, no mortality benefit. One-day decreases the frequency of hospitalization, symptoms and the heart rate. Don't stop digoxin if the patient is not ACI or the baby, but try to initiate them. No loading required. Usual dose will be 0.125 to 0.25 mg daily. 0.5 to 0.9 plasma concentration, narrow therapeutic range. They causes the nausea, vomiting and diarrhea, visual disturbances, yellow green halos and the problems with the color perception, supraventricular and the ventricular arrhythmia. Hydrazine nitrate combination, African American origin, can be taken. Beltil 37.5 mg, 20 mg ISDN. Start 1 tablet to increase till 2 tablets. If given separately, then both at least DID. Drugs not to be used: statins, CCB, NSAID, thiazolidine. Most anti-arrhythmic drugs except amiodarone, nutritional supplement, hormonal therapy. Device therapy will be implantable cardioverter defibrillator, non-ischemic or the ischemic heart disease at least 40 days post MI, with LVEF nearly 35%, with NYHA class 2 or 3 symptoms, or NYHA1 with EF lesser than 30%, or chronic medical therapy, who have the reasonable expectations of the meaningful survival for more than 1 year. Cardiac resynchronization therapy indicated for the patients who have LVEF 35% or less, sinus rhythm, left bundle branch block with a QRS duration of 150 ms or greater, NYHA class 2, 3, ambulatory 4 symptoms on GDMT. All the measures of a stage A, B, C until definitive therapy, coronary revascularization, mechanical circulatory support, heart transplantation or the resolution of the acute precipitating problem. Patients with a cardiogenic shock should receive the temporary intravenous inotropic support to maintain the systemic perfusion and preserve the end organ performance. Mechanical circulatory support, intra-aortic balloon pump therapy used for the cardiogenic shock allows the heart to rest. Ventricular assist diseases takes over pumping for the ventricles used as a bridge to transplant. Destination therapy or the permanent implantable VAD, cardiomyopathy, latissimus dorsi around heart, ventricular reduction, ventricular wall resector, transplant of the artificial heart.